Today's e-session will start at 6:15 p.m. Thanks for your patience. Today's e-session will start at 6:15 p.m. Thanks for waiting. of Oncology. The e-session will start soon. Thank you for your patience. Today's e-session will start at 6:15 p.m. Thanks for your patience. session will start at 6:15 p.m. Thanks for waiting.
Good morning, afternoon and evening. This is the conference operator. The European School of Oncology welcomes you to the e-session 565,001. Today's session is, Systemic Treatment of Early Breast Cancer, Anything Different in Elderly Women? Please note that this activity is CME accredited. At the end of the presentation, go back to the ESO website to complete the evaluation form and the CME multiple choice test. Mastermind competitors will be prompted to start the quiz, after having completed the evaluation. As a reminder, during the live session, all participants can ask questions live at any time by simply pressing on the relevant button at the bottom of the page. Questions will be received by Dr. Laura Biganzoli, of the Prato Hospital, Prato, Italy, who will discuss them with Dr. Etienne Brain, of the Hôpital René Hugouenin, Institut Curie, Saint Claude, France. Here is an extract of the policy which is published on our website in full. I will now hand over to Dr. Brain. Doctor, your line is now open.
Thank you for this very kind invitation. I'm going to share my screen to start this important session that is for today. So yes, it's my great pleasure to be able to speak to you about what is systemic treatment for early breast cancer in older women and why it is different. That's the main question, and I hope that I will be able to give you my insights, which is something which I really value a lot in terms of experience, and which needs to be expanded to the community that we represent in oncology. So I'm a medical oncologist working at Institut Curie in Saint-Cloud and Paris in France, and I'm going to cover this topic for you. So probably the main question is behind something that we need to learn from older person, that there is a constant increase in the incidence of comorbidities and their severities as well, which makes that the situation change above a certain age. And there is a constant competition for mortality between cancer and other causes for mortality. And that's the data from the TEAM trial, which shows that except for those patients 70 plus and with no comorbidity, as soon as you get one or two or more comorbidities, there is an unbalance which appears in terms of competition between the causes of death due to cancer, which is in red, and those which are due to other causes, multimorbidities mostly, which is a total difference compared with younger patients below 70, where the neoplasia always dominates the prognosis. So except the situation when there is no comorbidity above 70, you see that except this situation where breast cancer mortality is a bit higher, the other ones, the two boxes here, shows that multimorbidity play a major role, and we need to pay attention to this. So behind that, at first blush, you could think that for systemic treatment following a surgery for breast cancer, it is very unbalanced and very strange that we do not use that much chemotherapy, which is one of the major treatments that we can use in terms of systemic treatment after surgery. And you see that the surgery, after surgery, the use of chemotherapy in these large series from Holland and Belgium, you see that the number of cases receiving chemotherapy is decreasing very fast according to the number of comorbidities. So that makes a big difference in terms of use of these systemic treatments. And why is that? Because in these systemic treatments, you have chemotherapy, you have endocrine therapy, and you have targeted treatments like anti-HER2 treatments. And for chemotherapy, of course, the benefits and the benefit-risk balance is very narrow in terms of application to older ones. Why is that? Why is that? Because many domains are disabled or at higher risk compared with younger ones. I mean, myelosuppression is often greater in older ones, with a lower threshold for use of primary prophylaxis for febrile neutropenia. And it's an indirect reflection of the functional reserves in the bone marrow, which works a bit less well compared with younger ones. Heart disease is something which hits 30 to 40% of older adults in the US, for example. So congestive heart failure is more common in these older ones, and it increases depending on the underlying cardiac disease. Digestive symptoms, mucositis, delayed nausea and vomiting are also more frequent. Neurotoxicity, whether it's peripheral or central, can be also interfering with functionality and dependence. And many problems can be affected by these side effects of chemotherapy and affecting mobility and function. And then there is a constant need to look at renal function, which declines with age, and which requires an accurate assessment of the clearance through MDRD or CKD, AP, which are probably the best for older. But also, because these older patients may have crossed other disease in the past, they may also have long-term toxicity from previous cancer treatments, like cognitive impairment, those which I have mentioned just on my previous slide, cardiotoxicity, neurotoxicity, depression, anxiety. All these can have left prints on the body and on the health status of these patients, making more difficult to go through a new set of different steps of treatment, including systemic treatment and chemotherapy. Secondly, you have polypharmacy, which is very important. 1/3 of these older patients above 70 take more than 7 drugs, and with many interactions, potential interactions. And finally, there is all these social and psychological aspects, which are a fear for pain, for dependence, for frailty, and end-of-life aspects, which cover something which is very sensitive, very subjective, but which is really essential to these older ones. So we need to pay attention to that. Regarding chemotherapy, which is so a major component of systemic treatments, we know that most of the time, the resistance to the occurrence of side effects, the capacity, the ability to resist or to tolerate or to take treatments is a bit lower compared with young. You take anthracyclines, which are a major component for in breast, you see that the congestive heart failure risk increases according to age. Instead of starting significantly above 500 milligram per meter square of cumulative dose, from 400, it starts already with a risk which is at least 50% higher compared with patients above, younger than 65, sorry. So that shows you very well the functional reserve in the heart, which is different. The component are the taxanes. Taxanes are also a cornerstone of chemotherapy for breast. And we know that the risk of neurotoxicity, neurosensory and motor toxicity, reaches up to 30% grade 3-4 after 65 or 70. And even if these cytotoxic may have the same pharmacokinetics for the same similar renal clearance, the patients are at increased risk of neutropenia with docetaxel. And we do not use the standard dose of 100 milligrams per meter square in older ones. And that also shows the options that sometimes appear, like the use of formulation which may avoid the steroid premedication, like with nab-paclitaxel, which are quite promising and interesting for the older ones. So, having said that, yes, we have drugs, chemotherapies that we can use, but very often we need adjustments. So I remind you that you can click on the question Q&A button or post some question in the chat. Put that for the discussion. Please do not hesitate to interact. So, adjuvant chemo, does it work? Can we use it in older ones? Yes, we can use it. The CLGB showed that at least 15 years ago, through a large review of data from different trials led by this cooperative group in US. And they show that irrespective of age, the experimental arm trying to improve the therapeutic ratio of chemotherapy in these different trials did always better irrespective of age, whether you were below or over 65. The results in terms of benefit were identical, but the toxicity was different. And you had more side effects and more fatal events, even reaching almost 10 times what you see normally in standard modern trials covering the adult population. So we need to be careful. So who are these patients that we derive after 65 the most benefit from chemotherapy? As you can see in this large series derived from the SEER database, it's mostly when the hormonal receptor for estrogen is negative, like here, minus, where you see that the hazard ratio for the benefit provided by the chemotherapy shows a reduction of breast cancer mortality up to 25%, irrespective of age, but you see that it's present above 70 in node positive, but as soon as you mix ER negative cases and ER positive cases, you lose very often the impact of chemotherapy on breast cancer mortality. So adjuvant chemotherapy is useful first in ER negative, node positive or node negative, even after 70. That's the main message. This has been beautifully demonstrated in one of the most important trials, adjuvant setting, led by Hyman-Muss in older patients after 65. And we showed that according to the status of estrogen receptors, you have a different impact between a metronomic chemotherapy based on capecitabine versus standard chemotherapy with AC times 4 or CMF. The standard chemotherapy did always better than the capecitabine arm, but it was especially true in ER-negative cases. And this benefit diluted completely with longer term follow-up, which means that for the ER positive population, the duration of this benefit decreases and vanishes a bit with time and long follow-up. While for the ER negative population, it is really important, the use of standard chemotherapy. This is also something which has been very well shown recently in a large series published in the Lancet Oncology, showing that in the ER, in the triple negative breast cancer cases after 70, the use of chemotherapy, whether it was recommended, given or not given, would provide a very important benefit in terms of survival and overall survival. So that again stresses the very importance to select those patients and making the most of the use of chemotherapy in these ER negative breast tumors after 70. Again, don't forget to use the chat box or the Q&A button if you want to raise any question at the end of the other component which is important to discuss for systemic treatment beside chemotherapy is the use of anti-HER2 treatments. We know that the representation of HER2 positive disease in older ones is not so far in terms of frequency compared with younger ones. It reaches a bit 10 to 15% of these older ones. And it might sometimes be difficult to understand why it is difficult to deliver a full treatment of 1 year adjuvant of trastuzumab with chemotherapy, because based on what we see from the literature, 1 out of 5 patients after 65 may meet some difficulty in terms of getting a complete trastuzumab treatment. However, this risk increases according to age with the presence of comorbidities, and certainly it comes also with the different side effects that come with chemotherapy. And it raises the question of what is the best partner for this anti-HER2 treatment in terms of chemotherapy. And that's why many regimens have been explored, not specifically in older ones, but trying to use something which is milder in terms of toxicity, in terms of side effects, like the short 12 weeks of weekly paclitaxel as used by Tolaney with trastuzumab and giving excellent results in this node-negative breast cancer. Unfortunately, not completely described for the older population, but we can inspire ourselves from these results. One very provocative program led in Japan tried to explore the possibility to give trastuzumab, the anti-HER2 antibody, without chemotherapy, randomizing more than 300 patients between trastuzumab alone versus trastuzumab with chemotherapy, and in 70 to 80 years old patients, and with HER2 positive disease. With a follow-up of 4 years, and they couldn't make a difference in terms of the two groups of patients. However, we must say that the trial was very ambitious in terms of non-inferiority design, and it was completely underpowered to give solid conclusions. The only point that we can stress, and from this important program, is that it questions the need to always associate and combine chemotherapy with the anti-HER2 treatment for these older ones, knowing that the real demonstration, statistically significant, is not there. Another way to approach this question of selecting the treatments that we want to deliver and how to deal with approach of older ones is to try to anticipate the chemo-related toxicity. And we have a few models have been developed by either the group of Tampa with Martin Exterman with the CRASH score, or with Artioria and the CARG group. And the CARG has built this algorithm which allows to predict or to anticipate the occurrence of grade 3 to 5 toxicity. But more importantly, it has described, the group has described also a specific tool to anticipate also the risk of side effects to specifically adjuvant chemotherapy for breast cancer after 65. And you see that the risk predictors, which are listed in this table, one of them is treatment duration with a threshold at 3 months, which is determinant and one of the highest, one of the predictor which allocates the highest number in the total score, showing that the duration of treatment counts a lot for these older ones. And you have a few other items like the use of anthracyclines and the notion of falls, limitations in walking, all around dependence. But with this, you can predict quite well the risk of what you can expect. Adjuvant chemotherapy in this compares much more discriminant. It is more discriminant compared with the CARG score or with the Karnofsky index, which is always in default compared with what you can do. Again, I stress that you can go to the chat box. Don't hesitate to keep your question for the end or to write them. I think Dr. Biganzoli will be able to pick them up and to introduce them. So that in the general recommendation for chemotherapy and trastuzumab in older ones are mostly summarized here. The focus for chemotherapy is on ER-negative disease and HER2-positive disease. For ER-positive, we'll see that it's something more, do not know very well how to select them. The regimens which are validated are 4AC and 6CMF, and the sequential regimen using 4AC followed by taxane or 3EC followed by 3-docetaxel have not been validated in these older ones. The primary prophylaxis should be used vastly and more easily than what we do for younger ones. And when we have a chemo indicated, there is no restriction on the use of trastuzumab, knowing that TC or paclitaxel times 12 weekly match very well with the use of anti-HER2 treatments. There is a question mark here with the TCH with the carboplatin, but the dose of AUC6 with carboplatin is something which is very unlikely to be easy in older ones. Trastuzumab alone can be or could be considered, especially for unfit patients, and that's something which is still controversial, and shorter duration for trastuzumab is also an option. The last component that we need to discuss for systemic treatments is endocrine therapy. But for endocrine therapy, compliance is the issue. In general, the treatment duration is 5 years with some extension when the prognosis, given a large number of nodes involved, is present, may be discussed. But the discussion will be regarding compliance and the occurrence of side effects with tamoxifen, hot flushes, thrombosis, embolism, uterus cancer, vaginal discharge, cataracts. With aromatase inhibitors, all these issues are mostly musculoskeletal events with osteoporosis, fractures, arthralgias, dryness also, and some differences in cardiovascular and lipid profile. So that's where we stand. And I would say that what is the most important to understand is that the goal always is to try to make the person take regularly the treatment which has been prescribed. In addition, in this population for which there is often osteoporosis, biphosphonates may play a major role in adjuvant setting. That's a large meta-analysis by the Oxford Overview, which shows that above 70, there may be a large impact of biphosphonates on overall survival for these patients, which makes them a very good candidate. So, having said that, I think the last question is, for ER-positive disease, estrogen receptor-positive disease, do we know how to better select these patients for whom chemotherapy might add a benefit in addition to? And I must say that so far, we have very limited data, as always it is for the ones in trials. MINDACT, which tried to extract the added value of MammaPrint, enrolled patients all below 70. And the most important experience that we have is with the use of the recurrence score, which show a higher likelihood of death, but which is not necessarily something that you can correct with chemotherapy in older ones. As you see on this large series published in the Journal of Geriatric Oncology by Kizzy, chemotherapy was able to correct a high risk of recurrence with chemotherapy, but it was not the case in older ones. So we can still have some question whether the identification of these patients at higher risk can be really corrected by a right intervention and the use of. Maybe that's something which will be able, that we may have some answers coming in the next 18 months with the result of ASTER-70s, which exactly address the question of the addition of chemotherapy, you see, 4 cycles of chemotherapy and endocrine therapy, in those patients with a high genomic rate, like a high recurrence score. Those with a low genomic rate had no chemotherapy. And this large trial enrolled 2,000 patients, 1,100 were randomized between these two arms above. So we may get this kind of information soon, and that's important. Last point, because of this high level of side effects triggered by chemotherapy, there are many questions, research questions trying to decrease, de-escalate the use of chemotherapy and trying to replace it by optimized endocrine therapy. And that's exactly what happened with what's happening with Apalaches and the series of trials like PALAS or Monarchy and other ones. This one is really absolutely focusing on older ones. You see 70 plus, adjuvant chemo followed by aromatase inhibitors versus a combination of optimized endocrine therapy. Just for not 1 year, it is actually 2 years. It's a randomized phase 2 led by EORTC, which hopefully will bring some better documentation of how we can handle that, knowing that the primary endpoint is a 3-year distant relapse-free interval, which is something probably also ambitious in terms of differences sought. Again, I remind you that you can keep your questions, post them in the chat box, but don't. Finally, to close this lecture, I want to stress that beyond the tumor extent, the tumor biology, which all plays an important role. I mean, tumor biology, I said that ER negativity was really important for chemo. And when you have an ER positive disease, that's something which is more uncertain. Guidance to guide for the use of chemotherapy. General health status and with the geriatric assessment is something important. You can approach life expectancy, treatment, potential treatment side effects, but also patient preference and acceptability are key components. And I want to report to you the first communication on the age gap decision tool, a large prospective cohort led in UK, where 70 plus patients with early breast cancer were submitted to 2 questions, surgery or primary endocrine therapy, and the questions also on adjuvant treatment. And regarding the first question, we see that although surgery was doing always better than primary endocrine therapy if the patients were fit, actually they were more inclined to PET, to primary endocrine therapy, when information was given to these ladies on prognosis, side effects, etc., to help in the decision. So it was almost counterintuitive. And that means that behind, we need to respect what is behind and what are the feelings, the expectations. And I think the way you discuss the cases and the issues and what can happen with the use of the treatment is so important in these all ones. That makes very important also in terms of renewal, all the strategy which is regarding the use of primary or neoadjuvant treatment. One such example is the IBCSG TOUCH trial, which is basically for the HER2-positive disease, the comparison between a standard neoadjuvant treatment based on chemotherapy, weekly paclitaxel, plus 2 antibodies, anti-HER2 antibodies, compared with the use of a regimen which is completely new, no chemotherapy, but the 2 antibodies, trastuzumab and pertuzumab, the use of an endocrine therapy, but not only a single endocrine therapy, it's an optimized endocrine therapy with the use of CDK4/6 inhibitors, palbociclib. And that's a very provocative, very adequate question for an older population. And that's where we think that we can improve the management of these patients, trying to avoid the burden of chemotherapy as much as we can. So the key messages for me are, yes, we can sometimes at first blush think that there is an under-treatment, under-use of chemotherapy, but over-treatment happens very often and probably more often. Chemotherapy and anti-HER2 therapies, we do not use the same regimens or schedule as in younger ones. Duration counts. Sequential chemotherapy has not been well documented and studied in 3 months threshold is important to predict the occurrence of side effects. And we need to better select the right patient and the right tumor, focusing more on ER-negative disease and anticipate side effects. For the endocrine therapy, compliance is the issue. So the fight is really to, when you make a selection, tamoxifen or AI, is really to get the regular intake and no loss, no oubli by the patient. And there is a constant research on optimized schedule to replace chemotherapy. And probably we need to re-evaluate the value of primary endocrine therapy strategy with the optimization which is allowed today. And all that to stress that preferences and expectations are probably different in an older one compared with a young. So that deserves regular updates in terms of recommendations that IOC does very often. And the next update of the general management of older ones is coming. That's something which is discussed also at the annual conference, where you are all invited, or I suggest that you go on the website to look at the program, which is for the next conference in November next. Thank you very much. Questions?
Thank you, Etienne, for a very comprehensive, a very useful presentation. We received some questions from the audience, so I will try to transfer this question to you, following a little bit the order of your presentation. So the first question, the participant is asking why you just spoken about number of comorbidities and not the degree of severity of comorbidities. So is the number something adequate for really having the impression of the health status of the patients we are going to treat, or we need to go more into detail to see which is the severity of the comorbidity itself?
Thank you for the question. It is important. Both aspects are important. Incidence, the frequency of comorbidity increase according to age, and the severity as well. But you see that very often to make a difference between these steps of severity, it's not easy. Most algorithms are quite shy in terms of putting a threshold. And even in the last algorithm for predicting toxicity to adjuvant chemotherapy for breast cancer in 65 plus patients, the notion of fall, it's either one fall or none. But as soon as you get something that should question, that should be intriguing you and in your decision for the treatment, it's something which should ring a bell. So I must say that I don't know, I have no clear view about a scale of severity that you could use, but certainly that's something which needs to be fine-tuned.
Thank you. Then we have a question from Elaine that is asking, are modern targeted therapies safe in elderly?
If we speak about what is already approved for targeted therapy for early stage breast cancer, we can speak about anti-HER2 treatments. Anti-HER2 treatments, trastuzumab is quite well documented. Also that the registration trials have not always enrolled so many older ones. But when we come to the use of pertuzumab, neratinib, lapatinib as well, the data are less important and quite limited. And we see that any notch that we reach or any degree of increase in terms of the intensity of the treatment we bring also an increase of side effects very often. So, I mean, the standard remains trastuzumab, and the addition of all these possibilities is really highly submitted to the presence of patients who is completely fit. And I just want to comment that when you take a general population of early stage breast cancer, if you use a frailty tool to screen for frailty, almost 60% of your patients have an impaired test. So that means that the majority of your patients are at risk of a potential frailty that you need to dig it or you need to delve into further. So be cautious.
Okay, thank you. So another question is related to neoadjuvant therapy. We see in the general population, there is a dramatic increase in the use of neoadjuvant therapy in triple negative and HER2 positive breast cancer patients. So which is your view of this strategy in the older patient, and what do you think about applying the treatment with capecitabine or T-DM1 in case of no pathologic complete response? Do you believe that we have to follow this strategy? Of course, I'm speaking about elderly fit patients, or you would consider some difficulties in doing this in the elderly?
Using neoadjuvant treatment for triple negative tumors or HER2 positive disease should be discussed regularly. In fit patients, there is no reason not to discuss that for them, but always keeping in mind that the duration of the treatment counts. And if you embark on a sequential treatment for 8 months, you double the risk of difficulties in these older ones. So something which is 4 months is okay. And I think the magnitude of benefit of what provides this neoadjuvant strategy is the same in older ones if they're fit. So we should go. Then comes the question of post-neoadjuvant treatment when the response is deemed not enough important. And in this case, I would be careful to apply systematically the recipes that we got for younger ones, especially for the question of duration. But I would discuss that if the patient is okay, if she has recovered from surgery and gone through these 3 or 4 months of preoperative treatment with a good profile, I would certainly discuss either T-DM1 for HER2-positive disease with residual disease or capecitabine for triple-negative tumors. Certainly, maybe not with the same goal to go for 14 cycles, so for 6 to 8 cycles of capecitabine, but certainly doing something like that.
Okay, thank you. Then there are some practical questions. We have spoken about adjuvant therapy with trastuzumab. We have seen that there are clinical data suggesting that a shorter use of trastuzumab could be, in some cases, useful or better, safe, I would say. So the question is, do you think we can select upfront elderly patients who are candidates for a shorter duration of trastuzumab, or this is something that we have to evaluate during treatment?
I think my strong feeling is that upfront, you do not know always what's going to happen, because frailty, the difficulty for frailty is that it is, you unveil frailty with the treatment that you apply. Very often it happens after a few weeks or a few months or a few cycles of chemo, and then it's the tumble down and the lady or the patient is going bad. And the issue then is the difficulty to recover. The person will never recover to the previous state. So we need to be very cautious. Upfront, we need to screen for that with simple tools. And when there is any ring which suggests that something is potentially there in terms of risk, you should never hesitate to delve into much further with the geriatric assessment and all the intervention, preventive measures that you can set before embarking on a treatment. So my feeling is that instead of thinking that we need absolutely to give the full schedule, the same as in younger ones, we should be always ready to adapt and to adjust, and that's something which occurs in more than 50% of cases for me, for my practice. As soon as you listen to that, as you keep your ears open.
Okay, so I believe now I can combine 2 questions. The first one is looking at the data you have presented by about the studies run by MAS, the retrospective review of the CLGB study and the CLGB 49907. Do you think that there is room for a sequential therapy in a triple-negative breast cancer patients or in luminal B early cancer patient? Of course, we are speaking about fit patients. And more generally, when do you consider polychemotherapy in elderly patients? Do you plan to start at least the first cycle with reduced doses?
As a rule of thumb, I use the standard dose. As a rule of thumb, I never use sequential chemotherapy. But in some cases, when the person is really fit and the risk seems very high, I use it. But as a rule of thumb, no. And I always try to stay below the 3 months threshold. So 4 AC, 4 TC, 12 weekly paclitaxel always put you in this situation of less than 3 months. Then for ER positivity, the risk is really the distance from the time of the treatment to the potential relapse. And if you do not pay attention to life expectancy, if you're looking for something which is a benefit which dilutes with time and which may appear sometimes later than 10 years, it is really difficult. I think it's very challenging. And so I'm not a good supporter for this. And I don't think we have the cues today with the signatures to select correctly these patients.
Okay, thank you, Etienne. So there are no other questions coming. I would like to take advantage from this last minute to inform you, if you are not yet informed about this event, that on May 11, we'll have an e-session in which we will discuss clinical cases related to the systemic treatment of elderly cancer patients. It would be extremely important for us to receive these cases from you. So we really count on you, and you have time till the 11th of April to send us your cases. Please do this, and we will enjoy together another lively session. So now is 7 p.m. We are perfectly in time. I would like to thank Etienne for the presentation and all of you for having shared this time with us. And I hope you have found the session interesting for your clinical practice. Thank you very much.
Thank you, Dr. Brain, and thank you, Dr. Biganzoli. Ladies and gentlemen, the session has now concluded. If interested in CME accreditation, participants should fill in the evaluation form and pass the CME multiple choice test. To enter the CME section of the site, please close this window and go back to the ESO website. If you are a mastermind competitor, you will enter the quiz after the evaluation. The next ESO session will take place on the 31st of March, at the same time. And Dr. Carla Casulo, of the Wilmot Cancer Institute, New York, USA, will discuss with Dr. Astrid Pavlovsky, of the Clinical Research Center, Fundelu, Buenos Aires, Argentina. The following topic: How I manage relapsed refractory follicular lymphoma. Thank you for participating, and have a pleasant evening, day, or night. Goodbye.
Thank you very much to both of you for your great session, and have a great evening. Bye-bye.